Sleep regulation. This consists of two different mechanisms, the circadian rhythm and sleep-wake homeostasis. The circadian rhythm or process C can be remembered as the clock. The clock is situated in the suprachiasmatic nucleus. This governs many processes in the body, including sleep and wake cycle, body temperature, hormonal secretion, and blood pressure. As we told before, the exogenous sources which has an influence on the circadian rhythm are present, out of which light is the most important Zeitgeber or timekeeper. There are other nucleus which is situated in hypothalamus, though influenced by the master clock, they work independently to control many other mechanisms as shown in this figure. Apart from circadian system, which is governed by more endogenous and exogenous cues, the sleep and waking homeostasis, which is otherwise called as process S, is a parallel and concurrent system which governs sleep. This is the drive to sleep and to wake up as well. The sleep pressure develops during the waking period and it keeps mounting through the day, and at the end of the process, actually in the peak, you are made to sleep. You can see that like this is more by the biological brain activity releasing the adenosine kind of somnogens, and this somnogen makes one go to sleep. So this acts on the ventrolateral preoptic nucleus and keeps us away from getting aroused. Coffee is a very important opposite chemical which actually kills the adenosine, and if you keep drinking caffeine through the day, so this adenosine is gone and so is actually the sleep influence. So together, the two process model of sleep regulation is depicted in this picture, and thanks to Bobley's paper from 1982. The normal sleep wake timing is indicated by the black and white bars respectively. The blue line indicates the baseline condition with 8 hours of sleep and 16 hours of waking. During the time period that the blue line increases, the model is awake. When it reaches the upper threshold, that is, the upper sinusoidal black line is touched, the model goes to sleep and the line decreases. This process continues until it reaches a lower threshold and model awakens again. The green line indicates the effect of a 2-hour nap starting around evening 6 o'clock followed by a normal nighttime sleep. This is quite possible for some individuals in hot countries where like they have to have a daytime nap and then they can still sleep during the nighttime. The red line indicates the sleep deprivation, which is an experimental process of 40 hours of continuous awaking and skipping a night, and recovery sleep during the following day. This actually again indicates though the sleep pressure is maximal, you can only sleep for a particular period duration of time and you have to wake up. Wake to sleep transition is a very brief phase and it is quite difficult to recognize in every individual. It exists for a very short duration and it is more overlapping with that of the N1 stage of the sleep. Some changes include but not limited to just yawning. The person goes very quiet, is not able to perform very simple tasks, and also there is an alteration of memory and moments which is just prior to the onset of the sleep. There can be a closure of eyes, postural change, we try to tend to lie down, modulation in response to auditory or visual stimuli also exist. Now let us see some of the stages, descriptions of the sleep. This is more called as an ultradian rhythm as it actually alternates between the level of sleep. Sleep alternates between rapid eye movement sleep and non-rapid eye movement sleep in the sleep cycles. REM and non-REM sleep have defining EEG patterns and also neurological and physiological features though the function of each is not fully understood. Non-REM sleep is believed to function primarily as a restful and restorative phase and a period of relatively low brain activity. It consists of three stages: stage 1, stage 2, and stage 3. The non-REM sleep occurs mostly during the first 3 hours of sleep onset. In an adult, when he enters into the sleep, he starts with the non-REM sleep, which is stage 1, and progressing to stage 2 and then to 3, and only then progressing to REM sleep. Each sleep cycle is composed of the time it takes to move through the three stages of non-REM sleep and REM sleep. These cycles occur in approximately every 90 to 110 minutes, with decreasing non-REM sleep and increasing REM sleep duration over the course of the night. That is, you will be seeing prolonged REM sleep phases only in the second half of the night with brief periods of waking. From now on, in the next few slides, we will be seeing the various EEG patterns of each stage of sleep. To start with, the person or the child will be dozing off into sleep, and it will be a phase of transition into the sleep. However, with the eyes closed, everyone will have a specific pattern of EEG. This is defined as the predominant rhythm which is arising from the occipital lobes. With the eyes closed and in a wakefulness which is like at the lowest state, it is reactive and it causes this rhythm which is called alpha rhythm in adults. It actually goes into the frequency of 8 to 13. However, there is a maturity in each phase of life. It increases to a maximum of 6 Hz by the age of 6 months, 6 to 8 Hz from 7 months to 8 years, and after 8 it is greater than 8. This is the model which has been described in the picture of an alpha rhythm. This slide again describes the same alpha rhythm which is only termed in adults, and in children we always call it as dominant posterior rhythm, that is DPR. The table again shows the various changes in the rates according to the age of the child. Moving on to the next phase of sleep, which is N1 stage. This is the stage where the transition from wakefulness to sleep stage actually is complete, and non-REM sleep is there, and there is an intense sleepiness, and sometimes what we call as like hypnagogic hallucinations also happen. We can even see some brief involuntary muscle movements, which is called sleep starts, which can occur in this phase. In addition, the EEG pattern transitions from the alpha waves associated with wakefulness to a shorter frequency theta waves associated with the sleep. There are specific waves which actually start to appear as the child grows older and older. The first ones are hypnagogic hypersynchrony, which is only present in the infancy and then it starts to disappear as they grow older. Vertex shock waves are there to be seen only after 6 months, and slowing of the DPR activity is seen from 3 years, and rhythmic theta activity mostly after the 5 years of age. Then there is initiation of true sleep, which is the stage 2, that is N2 stage of sleep. In this non-REM sleep, with a decreased awareness of the outside stimuli, we see a decreased muscle activity which is relative to that of N1 stage. There is a characteristic ECG findings which are there called as the sleep signatures of this particular stage. One amongst them is actually the sleep spindles, which also is known as sigma waves, which are small bursts of high frequency activity as you see in the picture. The other one is actually the K complexes, which are brief bursts of high negative voltage followed by a large positive voltage peak and then a larger and slower negative voltage peak. It is thought that K complex represents a form of suppression of the cortical arousal in response to stimuli and may be related to sleep-based memory consolidation. In an average adult, he spends almost 50% of his night in stage 2, that is N2 stage of sleep. And next comes the final phase of non-REM sleep, which is the N3 stage of sleep, in which we see deep, slow wave sleep, and the individual is least responsive to any external stimuli. This is characterized by the delta waves, which are the slowest of all, as you see in the picture, on the EEG, which are high amplitude and low frequency waves. Most parasomnias like night terror, sleepwalking, and nocturnal enuresis, which is specific for the non-REM sleep stage, occur during this deep sleep stage. Then comes the REM sleep phase, which is in adults takes a bit of time, but in kids, particularly infants, it can be seen in the very few minutes of start of sleep itself. The REM sleep actually has EEG, which is a little different to that of the regular background, which is the low amplitude mixed frequency seen in the N2 stage. In fact, many a times it is difficult to differentiate from the wake state and other sleep states. There are no significant signatures which are seen, but you may see some of the sleep spindles to continue on in the REM sleep as well. The frequency of the waves completely changes as the child grows older, as it is seen, and after 5 years there is no difference between anything like N2 sleep and the regular REM phase sleep. The major difference which needs to be documented to qualify it as REM sleep is actually the chin EMG, where it is complete straight line and it's the lowest amongst all phases of sleep. The EOG, which is the eye movement detecting leads, will detect rapid deflection initial ones and then a slow recoil, which will be seen as the normal rapid eye movement of the sleep. The duration should be less than 500 milliseconds. With regards to sleep neuroanatomy and neurophysiology, we need to know the basics to understand the process of sleep. I will make it as simple as possible with this given two slides, one describing the arousal system and another one on the sleep system. The ascending arousal system or the ascending reticular pathway has got two branches. One is thalamic branch and the hypothalamic branch. The main nuclei in the thalamic branch is pedunculopontine nuclei and the lateral dorsal tegmental nuclei. The neurotransmitter is mostly cholinergic. In the hypothalamic branch, again, the brainstem and posterior hypothalamus are the pathways, and the hypothalamus is actually taking some of the neurons into it. The nuclei is locus coeruleus, dorsal raphe, and tubulomammillary nucleus. The neurotransmitter are mostly monoaminergic, which are norepinephrine, serotonin, histamine, orexin/hypocretin, and which can be secreted mostly by the locus coeruleus and the tubulomammillary nucleus. With regards to the sleep promoting system, the nucleus which is involved is ventriculolateral preoptic area, that is VLPO, and median preoptic area, which is MNPO, which inhibits the arousal system. That is it. The arousal system is the active one, and this nucleus actually sends signals to stop the arousal system. The neurotransmitter are mostly GABA and galanin, and sometimes melanin concentrating neuropeptide, adenosine, and melatonin are also involved. The non-REM sleep is mostly controlled by the GABAergic neurons, and the REM sleep is mostly controlled by the acetylcholinergic neurons. So in summary, the differences which are seen as an effect due to non-REM and REM phases are given here. So non-REM actually comprises of most of the sleep, that is 75 to 80%, and then REM actually is only 20 to 25%. The brain activity decreases from wakefulness and then it goes slower and slower in non-REM sleep. You have a slower heart rate, relaxed muscles, but not as relaxed as like the REM sleep. Blood flow to brain decreases and the breathing is slower. In fact, the body temperature is regulated to the lower set point than wakefulness. So the REM sleep, on the other hand, has got like a bit of brain activity which is going on. So increase in heart rate and then absent muscle tone, which is almost paralysis state, except for eye and then diaphragm. And the blood flow to the brain again like selectively increases and then the breathing is variable. Here the body temperature is not regulated. So one who's there in the REM sleep phase cannot shiver. They are not protected against the body temperature changes. From this slide, like we are moving on to the pathology or pathophysiology of disease conditions in the sleep. For that, we need to know what is actually the normative values for sleep duration. It has been recommended by the American Academy of Paediatrics that children have got a variable rate of sleep duration, but this has been given more in the context of the the country of America. However, we know that like from the Middle East studies and then in the Southeast Asian studies that children have got much less amount of sleep than what has been described by the American Academy of Pediatrics. This particular chart will show you what is the level of sleep which any child should achieve or like reasonably to achieve. This might be a little bit of a higher numbers, but like this is acceptable to most of the population of the world. With regards to types of sleep disorders, we can simply classify as like either the child has got less sleep, more sleep, a jet lag kind of sleep, or unwanted events during the sleep. This is very simplified format of classifying a sleep disorder. But when we go into any book, we have this classification which is existing. Sleep disorders in children has been classified by International Classification of Sleep Disorders version 3, which has been published about 3 to 4 years ago. This classifies it into insufficient sleep, a fragmented sleep, sleep related movement disorders, and finally central disorders of hypersomnolence, that is more sleep. In insufficient sleep, either the child is like deficient in either the total duration or delay in start, which is called more of like insomnia, and circadian rhythm disorders, which is more common in children of adolescent age, where they get to be delayed. Fragmented sleep is mostly because like there are some events which actually disturb sleep. One is obstruction, another one is central sleep disordered breathing. Usually the second form, which is the central sleep disordered breathing, doesn't cause that many number of frequent wakings. Cerebral related movement disorders are either simple or complex. I'm not going into the details of like what further it classifies into, but I can give you an example of like simple being bruxism and complex being sleepwalking. And finally, central disorders of hypersomnolence, where like they sleep a lot, which is comprised of narcolepsy type 1 and 2 and idiopathic hypersomnia. There are some other syndromes which have been described which don't fall into these classifications. One of them is Klein-Levin syndrome, and the other most important sleep disordered breathing is congenital central hypoventilation syndrome. When it comes to defining and managing the pathology of sleep, we need to have a start of where and how it all started. By this 4 or 5 important questions, we may be able to come into a conclusion whether the child has got enough amount of concerns with regards to sleep. The Barrett's mnemonic has been designed by the famous sleep team in Cincinnati, and they have given all the 5 questions where one of them, if it is wrong, then the child actually qualifies for more detailed examination. B for bedtime issues, C for excessive daytime sleepiness, A for awakenings, R for regularity to the bed, and S for snoring. We have some more detailed questionnaires which are available. The most commonest and then the world famous is actually the pediatric sleep questionnaire. In amongst them, we have taken the segment of sleep related breathing disorders alone for the checks in obstructive sleep disorders and given the questions of like about 22, which is actually a component of the pediatric sleep questionnaire. The original pediatric sleep questionnaire is actually 67 item questionnaire where like it is going to be more simple answers like yes or no. The SRBD scale is actually a subscale of the pediatric sleep questionnaire, and it is the only non-PSG tool which has been validated against a polysomnography to identify or disregard sleep disordered breathing. This is actually the pediatric sleep questionnaires SRBD component only, which is most commonly used to find whether there is going to be any problem at all. In Grade Ormond Street, we use this form. Apart from these questionnaire evaluations, the most commonest method of presentation is by the videos. So parents actually have got the capacity of a camera existing in every house, and so they can record the events whenever they want. Very effective to describe the condition on referral, and there happens to be a new method which is called video somnography, which is getting its shape but not been defined completely. St. Mary's Hospital in London have got some publications with regards to video somnography. There are some variables which has been described, but however, this is a little out of scope of this presentation. And some other investigations which is often been discussed in general pediatric clinic is about like taking an X-ray for adenoids or doing a cephalometry to quantify the amount of obstruction because of the anatomy. However, on a larger scale, we find that imaging has got very little role in managing anything in, at least in obstructive sleep apnea. So we don't usually use them. What investigations are required in a sleep disordered breathing and sleep disordered um, workups? So basically, we classify it either into respiratory sleep disordered breathing and behavioral sleep disorders, which is completely on the other side. So respiratory SDB and neurobehavioral. So most of the studies, the sleep study per se is not actually going to be different, but however, like the number of respiratory sleep disordered breathing is in a larger volume than the neurobehavioral. The studies which we do in respiratory sleep disorders are sleep oximetry, which is the home studies which is most often done in the past. Cardiorespiratory polygraphy, which actually means that like it is a polysomnography but without any EEG sleep staging. And finally, a full polysomnography which is attended in the lab. Home sleep studies are a vogue after the onset of a pandemic. In fact, actually, even before there was a policy to do home sleep studies, but this has taken full shape after the pandemic has hit in a greater way. The cardiorespiratory polygraphy can be a single night study, a 2-night study, or a split night study, just to make sure that like if we are dealing with the problem in two different settings. This is about classification of the modalities to evaluate anybody. The cardiorespiratory polygraphy takes the center stage in any of these conditions. Now let us see the usual components of sleep study at various levels. Level 3 to be the home sleep studies or like the beginner sleep study where we just monitor the SpO2 and heart rate. The level of accuracy with monitoring the saturation differs with the each and every monitor. In a sleep study monitor, the saturation averaging time is actually only 2 seconds, where more desaturations are picked up. You can see in this diagram, you can see the green actually is the 2-second averaging, and it's picking up almost like more than 6 desaturations for the same time with other averaging which is seen in the red color, which is the 5-second averaging, and the blue color is it is 10-second averaging, which are much less sensitive. The other components which can be measured are the bands which is in the thorax and abdomen, position sensor, nasal airflow, respiratory rate, snore monitoring, and ECG, which constitutes a level 3 study. Great Ormond Street does a lot of level 2 studies um, for in the form of cardiorespiratory polygraphy. When we add video recording and transcutaneous CO2 and EEG, it becomes level 1 polysomnography, and that is the term which we use for a full sleep study attended in the lab. Great Ormond Street also does transcutaneous CO2 in the level 2 study, which is very essential for respiratory sleep disordered breathing and titration of most of the non-invasive ventilation. A quick word about like the oximetry scoring, which is not in vogue anymore in many places, including GOSH. We usually don't use the system inside the hospital. This is more of a home study or a community study where like they just want to know whether the child has got reasonable number of desaturations. The problems are like the positive predictive value is really good, but the negative predictive value is to be cross-checked again by a full sleep study. You can see the two components which is there. There are clusters which is actually seen here. Um, you can see the clusters of desaturation which actually happens in specific phases. These are actually happening in the same time of like the group of oxygen heart rate changes, which has actually been grouped as well. So what it actually means is this desaturations are happening in the active sleep, or what we call as REM sleep. So this is a good correlation in oximetry. However, like we cannot accurately state that like these were the times the child was in REM sleep. So this is a very crude estimation. Essentially, a full sleep study is always required, or at least a cardiorespiratory polygraphy. An example of a normal sleep study. This is the exact same montage which we use in GOSH. The first top band is actually the full night of sleep study, and the bottom band is actually a small slice of it, like the blue line, which actually takes a slice of the full sleep study, and then we have enlarged it here. The SpO2 monitoring is in the top band, the heart rate is actually in the second band, and then the transcutaneous CO2 is in the bottom. So this is a normal sleep study, a good running flow, and then like there is normal saturations, everything is within normal limits. There is no evidence of hypoventilation or any gas exchange abnormalities. Now when it comes to an abnormal sleep study, we have differences which can happen actually. Again, this is again an illustrated montage. It is not actually the same recording what we see in Great Ormond Street. The nasal flow actually has got like a diminishing effect here, and then there is a breakthrough effect here. Thermistor is also used because like that is actually the international norm. We have to have a temperature probe which actually is there in the nasal part, which will detect the apneas. If you see the thoracic belt, usually the thoracic belt actually should be in synchrony. Now thoracic and abdominal belt are in asynchrony, completely opposite. This is called paradoxical breathing. When the chest goes up, the abdomen goes down. So this is called paradoxical breathing, which has been happening, which is a form of obstructive breathing. When it comes to desaturations, when the apnea happens, the desaturation starts, and then it persists even when the breakthrough breathing is there. So these are the abnormalities in this study. Another example for what is called as like central hypoventilation. So this is a study where like we have seen the oxygen saturation to be completely abnormal, and there is a stage of like child starts to sleep, and then like there is a desaturation which is happening. Now when we take a slice of it and then like enlarge it, we can see that like there are desaturations, but the reason for the desaturation is given here. The thoracic and abdominal belt are moving in the normal synchronous direction, and after that there is a bit of like slowing, and then there is completely no effort here. So this is a typical central pause in breathing or central apnea. This not only gives rise to a desaturation, but it also gives rise to a hike in CO2 levels. So this is central hypoventilation, which is seen in typical neuromuscular disorder patients. So with the given recording, we have some components used as indices to report a sleep study. The sleep staging, when it is going to be a polysomnography, we have to do it as a full study. But in cardiorespiratory polygraphy, we usually classify it as like active and quiet sleep, which are crude representations of REM and non-REM sleep. The oxygen average, the lowest point of oxygen, and then the time spent below a particular saturation is also to be reported. Carbon dioxide is specifically measured during the sleep time, and this is a very good indicator to add as a piece into the puzzle. The nasal flow or thermistor, which are sensors used for detecting the airflow through the nose, and also sometimes to detect the open mouth breathing. With this, we usually find an apnea hypopnea index which has been reported. The OAHI is the obstructive component. The CNAHI is the central component. With this, we usually have the report completed, but American Academy of Sleep Medicine actually has got the other components which also needs reporting, where the respiratory effort related arousals can also be added, and the RDI, the respiratory disturbance index, is the final one where AHI and RERA are together. Patterns of breathing is also to be described. Snoring levels can be documented. Uh, the respiratory impedance bands actually show the pattern of breathing as well, and the position of sleep in which the most events happen are to be reported as well. With regards to management of sleep disordered breathing, we have some modalities which is quite conventional for managing the obstruction. The surgical management, which actually includes tonsils and adenoids removal. There are non-surgical methods which is also be used. So with regards to surgical methods, as we said, like it is adenotonsillectomy, which remains to be the topmost priority. The valvo-palatal insufficiency surgeries can also improve the breathing methods, which can also be used. Sometimes like there needs to be a revision of like a adenoidectomy and tonsillotomy. When it is done, like we have to shape the tonsils once again. And finally tracheostomy, where it is going to be the last option anymore. When it comes to non-surgical management, if it is going to be a child with Pierre Robin or like a structural malformation, then nasal prong in a younger age is actually a good option. And when it comes to medications, most of the medications are for like milder forms of obstructive sleep disordered breathing. Non-invasive ventilation comes as the next most important method of management, but equally there are dental interventions like myofunctional therapy, which has occupied a very important place these days. Now let us go into the last component of this presentation, which is actually the neurobehavioral part and the sleep hygiene, which needs to be advised to parents. What actually is sleep hygiene? These are list of things which we are advising to parents and patients as a modifiable practice, which will increase the quality of sleep and allow sufficient time of sleep and also prevent daytime sleepiness. There are several domains which needs to be covered in this, and then the sleep environment, sleep routine, and daytime activities are the essential components which needs to be told. What is the ideal time to bed? Everyone has got their own timing to go in, but however, like a consistency is the most important thing we are going to advise. An inconsistent sleep schedule is actually a root cause of many of the behavioral difficulties because it leads to a shorter duration of sleep and also frequent wakings. More frequent exposures to late sleep actually has been correlated well to increase in body weight or adiposity. So fatter the children, there is a possibility that like in history, there can be a delayed sleep onset which is present. What about sleep environment? We have to have a quiet environment, and the environment, what I mean is actually is not the place where we do other activities. It should not be too bright, too loud, too hot, or too cold. And of course, like bed sharing, this is to be decided upon the cultural practices. Children with neurodisability sometimes are advised with sleep positioning systems which are not actually of great benefit on looking in greatest like bigger studies. The respiratory function and sleep quality has never improved. When it comes to bedtime routine, we see a common practice of some steps which has been followed by the European and American families. However, like there seems to be a little cultural difference between the two continents, where uh, the European style actually allows most of the most of the family activities to be involving the child. An after dinner bath is very common, and dressing, in particularly getting into their pajamas as a night dress, is very important sign for the child to be going back or like completing the day and then like going to the bedtime. Telling stories and singing lullabies as a gradual diminution of the external stimuli is also an indicator for them to go to sleep. And putting the child to bed and followed by a good night kiss actually uh, gives the sign that like the child is going to be left in the room and they have to sleep, and then leaving the child alone in his room commemorates this event. With regards to sleeping aids, which are otherwise called as like transitional objects and transitional phenomena, these sleeping aids are quite common in an urban setup than the rural setup, where the objects or habits facilitating to fall asleep is a provision to give the child a sense of comfort. They are very happy to go into sleep with that kind of aid. Pacifiers, blankets, toys, stuffed animals, or children's thumb for sucking are usual or common sleeping aids which the children has been known to use. As I told earlier, it is more common in the industrialized or urban societies than the rural societies. Children sleeping alone were more likely to use the sleeping aids rather than children sleeping or co-sleeping with that of the parents. There can be many other methods to put the child into sleep, but these are of large debate. Now, when we come into advising or counseling parents with regards to sleep hygiene itself, we deal it in a professional method with methodologies to make them achieve the good sleep hygiene. There are some methods which has been described, which I will list it down, and this may not be of great importance when it comes to the exams, but just to know about them will be very good. Extinction, that moving away of parents from the child's bed is extinction, which can be at a specific time. There can be a gradual extinction, there can be a minimal checking, systematic extinction, and positive routines preceding the bedtime, which actually means that like a parent is going to leave, an incentive kind of extinction, and programmed awakening to make sure that like the child understands that like the parents have gone, and sleep remodeling. All these are methods to make the child sleep alone and then create their own bedtime habit. In infants, the methods which are to be used, which has been described before, is usually for the behavioral insomnia. They are not able to sleep alone, and this happens only after the age of 6 months. They are not less than 6 months, like it is very unusual. By 6 months of age, if the child is not able to have a consolidated sleep, then it is a problem. Infant sleep is addressed based on what are the cues for the sleep, and then the self-soothing techniques which needs to be encouraged, and day and night differentiation for the infants. The sleep initiation can be by unmodified extinction, that is like blatant leaving the child alone after the feed has been given, and then the child is not visited by the parent once again even if they cry. There can be a graded extinction and parental presence extinction depending on the distance where the parent is seen from the crib. For the reasons of frequent awakenings, we can do a scheduled awakening so that like the child is reassured, so that like the parent is available at that time. There is a preemptive waking schedule, that is 15 minutes before routine wakings. Increasing the gap between the wakings can also be happening, and these are methodologies which is used for frequent awakenings, which is to reassure the child. In 2 to 6 year olds, it is a little different. There is always a problem of limit setting. They don't want to go to bed, and sleep hygienes are not very well followed. They are quite rebellious at this age. So modeling from parents starts actually the way forward. In this age group, there is a peculiarity of like nighttime fears. Ghosts are very important phenomena which is getting introduced to them. So CBT is the way forward, and relaxation techniques are advised by the psychologist, and systematic desensitization for specific sleep associations or like sleeping aids which has been there can also be used to get rid of the monster habit. They can use their imaginations to make a creative monster and then write a letter to them as well. These are tactics which is used by the psychologist. And finally, the 6 to 11-year-olds, where we have a normal sleep time of 10 to 11 hours. A progressive shift is happening. It is not because of them, it is because of their hormones which actually has started kicking in, and some of them are night owls, or some of them are like morning larks. They go to sleep early and late. Limit setting by the parents is for themselves. It is not actually by the parents, it is mostly by the child. How late to watch the television and do the homework on the internet is actually to be decided by a specific predetermined rule. A faded bedtime and faded bedtime with the response cost is also to be used as a modified method to make sure that like they go to sleep at particular point. CBT can also be used to control fear and phobia.